Bueno, ¿cómo les va? Nuevamente. Les voy a dejar un subtitulado de una charla entre Favio Taccone y el profesor VIncent. Toda ahí la pauta que está medio armado para comentar más que nada acerca de las nuevas guías de la campaña de sobreviviendo a la sepsis desde este año. Sobre todo él va a hacer una crítica bastante dura en algunos puntos, más que nada, por ejemplo, lo que tiene que ver con la reposición hidroelectrolítica, el uso mm, de la cantidad de volumen, sin controlar exactamente con algún parámetro hemodinámico, los casos que se menciona, el gasto cardíaco, y hacer mucho énfasis en tener un criterio en adaptar las guías a cada centro. Si bien también pone que las guías son muy útiles y prácticas, pero tiene varias deficiencias que las va a comentar. Bueno, no les adelanto más, este, los dejo con el video.
Hello to everyone. Welcome to a new EasySem e-chat. I have the pleasure today to interview Professor Jean-Louis Vincent. And of course, I will like to discuss with him about the new Surviving Sepsis campaign guidelines. So the first question I have for you, are you happy with these new guidelines?
Well, I am both happy and unhappy in a way. Well, first of all, we need to congratulate the people who worked on it, because it's a difficult task, and I like guidelines. I think we must be in favor of guidelines for the non-expert. May I remind you that we started the sepsis guidelines in Brussels, nearby Brussels, in Genval, with the International Sepsis Forum. And then the American and the European societies came on board, and it became the Surviving Sepsis campaign. The problem is that the group expanded very much to 60 people now in a single room, and they want to have guidelines that would be applicable as they are everywhere in the world, which in my mind is a mistake. There is no point in saying that lactate levels cannot be obtained everywhere. No, use the guidelines to go to your authorities and say, look, we need to measure lactate, instead of writing, it may not be available. Then the authorities will say, well, they are knowledgeable. They know that there are some priorities in our healthcare system. Okay, you will continue to do without lactate. Just to take one example. Monitoring systems is the same thing. There is almost nothing on monitoring systems. Oh, no, it's costly, difficult. Well, say what's optimal, and then people will apply what they can apply and fight to get more to treat these patients. And the other things that I don't like very much is that it's a one-size-fits-all. Do this, do that, blah, blah. Can't we be doctors wherever we are around the globe? They should be doctors to individualize therapies. Don't say, we don't need this, we don't need that. No, purification techniques, no way. Transfusions, no way. This, no way. No, please, can we think a little bit at the bedside? Can we look at cardiac output? Cardiac output is mentioned only once, just to say that, fluid administration can be helped with measurements of cardiac output. SVO2, well, it's hardly mentioned. We don't know how to use it when we read the guidelines. And that's a pity, It's really, even though it's for the non-expert, we should not make it too simple. 65 millimeters of mercury arterial pressure in every single patient. It does not make sense. We need to individualize all this. The place of inotropic agents should be individualized. Where is it? It's not there. So, good exercise, but they could have done a better job.
You almost gave all the responses to the question I want to give you only once, which is already a good start. But let's discuss about a few points I think are interesting for our audience about the initial resuscitation. So there is still this 30 milliliters per kilograms initial bolus. Now it's within the first 3 hours, and they recommend this dynamic measurement of fluid responsiveness, as you mentioned. And they said basically if you want to guide resuscitation, you don't need lactate CVO2, maybe you can use CRT, capillary filling time. Is it a bit, as you said, a little bit too direct, and how do you interpret these recommendations?
Yes, indeed. There is too little about the initial resuscitation, which is fundamentally important. They still come back with it's just a suggestion of giving a given amount of fluid over 3 hours. 3 hours, that's so long. They should advise for half an hour, and then we should have at least an echo assessment or perhaps a cardiac output assessment to individualize the needs for fluids. Why giving amounts of fluids over 3 hours, you know? And also it's so individual. I mean, a patient with pneumonia may need much less fluid than a patient with generalized peritonitis. Where is it? Where does it appear? Nowhere. The admission to the ICU within 6 hours. 6 hours! 5 minutes, 10 minutes, not more. If the patient is critically ill, if the patient is, okay, maybe it's sepsis, okay, you may have 1 hour, okay, but not more. Unless there are ethical limitations, which is, of course, that should be mentioned as well. So the initial resuscitation is not very well defined. The type of fluids either. You know, there is nothing wrong in giving saline solutions. Saline solutions cannot be harmful unless there is hyperchloremia. Hyperchloremia cannot be good. Where is it written in the guidelines? Nowhere. But that's the problem. I am here at a meeting on nephrology. We discussed the role of hyperchloremia on the kidneys. It does not appear in our guidelines, as if we didn't know why we should be careful with saline administration, etc. You know.
Well, I have then a point that you touched a little bit, which is the blood pressure. No, we have this number 65. That is probably the association of a level of pressure to an increased risk of mortality in a large registry, which to me is nothing physiological because we don't have 65 millimeter pressure now. So my point to you, the guidelines underline the point that we have a study comparing, let's say, 65 to higher levels with some effect on the renal replacement therapy. And then we have a second study in elderly patients where permissive hypotension was, let's say, provided the same results in terms of outcome. Again, a little bit suggesting 65 should be kind of magic bullet number to start with. Now, my question again to you is, how should we probably do it at the bedside? Is 65 a good starting point, or is just the minimum threshold to obtain in these patients, and then consider how to individualize?
Well, first of all, I think we should stop focusing only on mortality, because all studies targeting mortality have been negative, except for harm maybe, but for benefit, nothing. Transfusions, nothing. Hemodynamic measurements, nothing, etc., etc. So it's not surprising that for patient populations, you know, any study that will look at an optimal arterial pressure in populations must end up with negative results, with no difference in outcome. But we know that people who are older with atherosclerosis, with a history of hypertension, will need a higher blood pressure than the others. We all know that some patients in the ICU will make urine when the blood pressure is a little higher than 65. Why don't you test the system? Why can't we be doctors at the bedside trying to increase arterial pressure to a somewhat higher level in an elderly patient in particular, and see if the patient improves? You know, it's basic medicine, which is totally forgotten in large prospective randomized controlled trials showing no difference in mortality. We need to revisit all this and go for personalized medicine.
Another point that I think is interesting is about how to raise blood pressure when, of course, the patients remain hypotensive. There are some recommendations, for example, to add vasopressin first and then epinephrine to norepinephrine in case of persisting hypotension. And then this recommendation about steroids for ongoing vasopressor requirement, which is a bit vague. How do you see these 2 points?
Well, I would like to speak about vasopressin for quite a long time because there is much to say. And as you know, we have worked on this. So there is some evidence that it could limit edema formation and it could protect the kidneys and increase urine output. The celepressin study was totally negative. I didn't want to participate because there was no hemodynamic measurement. So the risk is that people focus only on blood pressure and forget about the rest, flow, oxygen delivery. And hopefully celepressin did not show harm, but we missed the opportunity to develop a new drug. With respect to corticosteroids, yeah, when you put together the Australian study with half of the patients who were not in shock, and the Annan study where the patients were really in shock with a 40% mortality rate, that's septic shock. And you can realize that corticosteroids can be beneficial when there is real septic shock, but not in sepsis without shock. That's for sure.
I have maybe a last question for you, because we would have many of those, of course, but you are limited in the concept of the e-chat. Are there any recommendation you find a little bit too rigid, or maybe something that you would like to have more discussion about into these guidelines?
Well, first of all, I have always fought to have something on endotracheal intubation in septic shock. It's totally missing. There is nothing there still now in the guidelines. Secondly, I want to emphasize that sedation may not be necessary. There is nothing about it in the guidelines. Actually, the guidelines speak about pulse pressure variation or stroke volume variation, which is applicable only in deeply sedated patients. It's not even mentioned there. It's crazy. And, you know, some things are simplistic. Don't give vitamin C. Well, the recent meta-analysis are rather in favor of vitamin C, so let's explore it further. We should not discard it altogether. Likewise, you know, for nutrition, what is the message you got? That if possible, we can start nutritional support. That's too vague. If the patient is in severe shock on high dose of vasopressors, you should not start enteral nutrition. Start it when hopefully the gut function will be at least possible, when oxygen delivery will be improved. It could be dangerous to give enteral nutrition to a patient with some ischemic gut.
I want to thank you for all this very thoughtful information and opinions that you gave us. I think it's a nice point for the audience to say that guidelines are guidelines. As you said, they can help non-expert in managing sepsis, but behind this recommendation, we need a little bit of consensus. There are still open points which are not so clear and defined. And I think it is nice in our discipline, we can still think at the bedside how to adjust these guidelines to our patients. And I hope maybe in the next EasyChem, we will have many pro and con debates discussing all the different points. So thanks again for all this information you gave us, and see you at the next e-chat.
Thanks, Fabio. Ciao, ciao.
Bye-bye.